Okay.
All right, are you ready to go?
You have, is everybody here?
Yes.
I see Dr. Says, Dr. Dubinsky, Dr.
Are we ready?
Yeah, let's just have Dr.
Look at that.
And that guy, oh my God.
I'm the person to bring up how hard it is to get authorization.
Exactly.
That's right. That's right.
So when you're going from weekly, every other week to weekly, Myra, like they want to switch you to Entercord, in your age, they want to approve it for 6 weeks.
You don't know what.
That's never ending.
Okay, everybody, sit down.
I'll be.
An introduction.
All right. Before we start, there's a live course in endoscopy being held right here at Mount Sinai Hospital next Friday, and the principal leading reports are here. Dr. DeMayo, Dr. Kumta, Dr. Nagula, they're here, and we're ready to go. Anybody who's Sinai faculty can come for free. It's going to be across the street at the Go-On.
No. Davis Hestville.
Hestville.
Davis Auditorium.
Davis Auditorium. 2 blocks up.
All right, everyone. So we have a very special controversies in GI today. It's our last one of the academic year. We have, last but not least, Dr. Maia Kayal here. She's a second-year GI fellow. We have an all-star IBD panel for what's sure to be an exciting discussion. So thank you, Maia.
Thank you, Dr. Portman, for that wonderful introduction. So good morning, everybody. Thank you all for coming. Thank you for our amazing panel for being here. I chose to talk about treat to target and IBD for our controversy series, specifically because I've witnessed a lot of heterogeneity in treatment goals and the extent to which physicians are therapy to achieve those goals. Today is an interactive discussion. The cases and the talks and the evidence that we'll review are meant to be interactive, so do not hesitate to contribute. So our aims today, to understand the role of treat to target in IBD, to evaluate the evidence behind the guidelines and the recommendations, and to identify additional treatment targets. So as you all know, just a brief overview, we know that Crohn's and ulcerative colitis are progressive inflammatory diseases that are characterized by episodes or periods of relapsing and relapses and remissions. And there's accumulating evidence that suggests that there exists an early period in the disease of immunologic change that precedes symptoms and bowel damage. And the idea is that if we use aggressive treatment during this window of opportunity, we could potentially change the course of the disease, block the progression, and decrease bowel damage. But it's not enough to just treat during this window of opportunity. It's important to continue with tight control and monitoring, which we define as a serial, close observation of patients, the reevaluation of their symptoms and their targets, and the adjusting of their therapies to their target goals. We find that tight control and monitoring could decrease inflammatory activity and decrease the progression to bowel damage. Tight control goes hand in hand with treat to target. This concept has been used in many other immune-mediated diseases, most successfully in rheumatoid arthritis. It's a proactive therapeutic approach. We predefine a specific target. We then reassess the patient during regular predefined intervals using objective markers, and we continue to adjust the therapy until we meet that target. So how do we apply treat to target in IBD? The application is actually a shift away from traditional management where we used to focus on symptoms and treatment was escalated based on symptom report. What we essentially do now is we develop a baseline assessment of the patient. We risk stratify their risk of progression, and we develop a target for them. We start the therapy, and then we continuously reassess at predefined time intervals whether or not they've met the target. If they haven't, we adjust their therapies, and then we repeat the cycle. And again, the ultimate goal behind treat to target in IBD is to really control intestinal inflammation, prevent the disease progression, and block bowel damage. The targets that we have in IBD come from the STRIDE recommendations. So we're going to talk about how STRIDE was developed. Spoiler alert, 3 of the 4 people on the panel developed the STRIDE recommendations. So,
You better not say it.
exactly. So let's all be very polite. The idea behind the STRIDE guidelines was to really develop a cohesive set of recommendations based on expert consensus that could help guide therapy in clinical practice. The team was put together in 2014. It was completed by the IBD, and essentially they selected 28 members to a steering committee. And the steering committee was made up of, as you can imagine, international expert IBD physicians. And they first determined 4 questions. What is the target? How can the target be measured? Is the target already in use? And what's the data that's supporting the target? They then identified 6 groups of targets that they thought would be most useful for clinical practice. These were clinical, endoscopic, histological, imaging, biomarkers, and patient-reported outcomes. And then they got 6 groups of really cool GI fellows, and they had them go through all of the literature review regarding these targets after developing a search string. Then the groups of GI fellows developed a summary report where they basically put together all the evidence and drafted a set of draft recommendations. And then they went to vote in 2015 at a consensus meeting. So the statements were proposed, and the voting was anonymous, of course. And agreement was achieved on each statement if greater than 75% of the people involved scored the statement greater than 7 on a 1 to 10 scale. And so what that resulted in was guideline recommendations for Crohn's and recommendations for ulcerative colitis. And the STRIDE guidelines determined that the optimal target for Crohn's and for UC was a composite endpoint of both clinical and endoscopic remission. And clinical remission was defined as resolution of abdominal pain and normalization of bowel habits with an ultimate goal of normalization of quality of life. And endoscopic remission was defined as a resolution of ulceration on colonoscopy or imaging if colonoscopy was not possible. There wasn't enough evidence at the time to formally recommend biomarkers and histology as optimal targets. The same guidelines were created for ulcerative colitis. Again, the clinic is a composite endpoint of both clinical and endoscopic remission. Clinical was defined as a resolution of rectal bleeding, again with the ultimate goal of normalization of quality of life and bowel habits. And endoscopic remission here was defined as a resolution of friability and ulceration on flex sig or colonoscopy. Basically, the patient's Mayo score had to improve to a minimum a 1, obviously at best a 0. And again, at the time that the STRIDE guidelines were created, there was insufficient evidence to suggest that biomarkers and histology should be implemented as optimal targets. But with all due respect to our esteemed panel, there were significant limitations of the STRIDE guidelines at the time. There was no good evidence behind a lot of the guidelines. There was no randomized controlled trials that compared an intervention approach that was based on symptoms to an intervention approach that was based on endoscopy. The targets that were proposed might not work for everybody. In patients who have complex Crohn's disease, a long history of disease, the target of mucosal healing might just not be achievable. The safety of the treat-to-target approach wasn't established yet in certain patients who are more vulnerable to drug toxicity, like the elderly patients, but also in the patients who we don't know would certainly progress to complicated disease. There were significant challenges of applying treat-to-target in clinical practice, convincing your patient to adhere to a strict regimen of monitoring and therapy. And then finally, we didn't have a good idea of cost effectiveness or cost utility for these patients. So now I'd like to shift towards our case presentations in order to kind of further understand the guidelines, the evidence, the limitations. This is our expert panel. So I'd like to welcome Dr. Columbell, Dr. Dubinsky, Dr. Legnani, and Dr. Sands in alphabetical order.
The first question is, where did she get such flattering photographs?
Yes, I have to say, this is the most photogenic group of IBD experts in the country.
I would know that.
This was not photoshopped. So our first target, the first case will focus on mucosal healing as a target. Our case is a 35-year-old male who has recently diagnosed Crohn's ileocolitis who presents to discuss management. After you have your shared decision-making speech, you decide to start adalimumab. You discuss the goal of symptom control and mucosal healing with the patient. He asks, why is mucosal healing important? Why do I care about mucosal healing? And how likely am I to achieve mucosal healing? So, expert panel.
So Bruce, what about how scientific based are these recommendations? It sounds great, I mean theoretically, but is it proved that this is the way to go?
It's not proved in randomized controlled trials, but there's substantial observational evidence that patients who are able to achieve goals have better outcomes, less surgeries, less symptoms over time, less progression and complications. So until such time as we have RCTs that prove this, these are coming, basically we have to act with the information we have.
How do you know that a patient is going to follow that first graph that she showed where it makes it look like you're doomed? If you don't take that window of opportunity, your future is bleak.
That's a really critical question, and actually one of the sticking points with patients, since we don't have the perfect way to predict who is going to progress. But the truth is, the majority of patients with Crohn's disease do progress to a complication that may require surgery or complicate their disease. It's good for fistula. We know that even in the present time, at least 60% of patients end up needing surgery over 15 or 20 years.
But there's no crystal ball at the
There's no
outset.
crystal ball. There are factors that increase the likelihood. Early need for steroids, perianal disease, ileal or ileocolonic disease, all these do increase the individual risk. And then there are risk models that Marla could tell us more about that incorporate other factors such as serologic factors into the model and are reasonably predictive of who's going to have progressive disease.
So Marla, what do you tell this guy when he says, what are you talking about?
So I think what Bruce is getting at is you have to start to stratify our patients because what I will tell you is that based on some risk models we have, 85% of patients will progress to having a complication, meaning either stricturing or fistulizing, predictably. If you go back to Jocko's slide way back when we had steroids basically in 5-beta phase and a little bit of ignorant, now sprinkled in, 80% of patients by 10 years ended up with surgery or having a complication. So what we see is that if we don't get a patient who's at high risk of developing a complication and get their mucosal healed or minimize bowel wall damage, they're going to progress. I mean, that's the problem, is that you need to predict up front. You can't wait for a patient to declare themselves more complicated. It's too late. That's where that window of opportunity. The question is, we don't know what that window is. I think that's a fair comment. We all define early disease intervention differently. All I can tell you is on the ped side, when we looked at 90-day utilization, meaning early on, at 90 days, we did change the natural history in pediatric patients when we applied biology.
So
What
Jean-Fred,
about age of onset? Age of onset.
So pediatric patients tend to have a more aggressive phenotype. The French group really helped us see that. And we've also shown that advancing age in pediatrics, actually, meaning 16, 17, 18, which is closer to what an adult gastroenterologist would see, those patients did worse than patients who were diagnosed less than 10 because they had a more colonic type of IBD, which didn't progress to strictures and didn't have fistulas. So age of onset looks like less than 10 behaves differently than above 10.
Jean-Fred, the implication of this is treat early and treat aggressively.
Yeah.
And Peter, the question to you is going to be, what are the practical implications of implementing that strategy?
Okay, so the first thing that I want to mention is that I completely agree with you. This is theory. This slide and so on, and it doesn't apply to all your patients. So we have to translate the theory and clinical trials to clinical practice, which is not always easy. So Bruce is perfectly right. All this evidence about mucosal healing, and actually it should be called endoscopic healing instead of mucosal healing because there is a controversy as far as the definition as well, is based on retrospective data. There is one ongoing trial which is called the Reactive.
We'll get into that.
Oh, sorry. Anyway, so this is based on retrospective. This is based on retrospective data. Second point, which is key, and I'm sure you will come to, what is the degree of endoscopic healing that needs to be achieved? Is it acceptable to leave some mild ulceration, some after lesions, or should we aim for complete healing of the mucosa, which is very difficult to obtain? So again, there are a lot of points about that needs to be solved.
Peter.
next question usually is, do I need to be on this medicine for the rest of my life, and what happens? And then their spouse asks, are they going to get cancer? Right? And that's the conversation that always occurs. And having that conversation, I think, very early is important, even before you click on the e-prescribe that the medication is going in and start the approval process when the family practice person who's reviewing it from the insurance company wants the patient to have been on 2 months of steroids or Imuran for 3 months or mesalamine or something like that. Okay, so those are the practical aspects that I see when I sit across somebody like this. But the mucosal healing part that John Fred said, mucosal healing is not the same as complete. Endoscopic healing is different from mucosal healing. And the Crohn's disease activity indices that I think Maia will get to are really important to know and to understand what mucosal healing means within that.
Can I make a comment also about this notion between endoscopic and mucosal healing? I prefer the term luminal healing since cross-sectional aspects of this are pretty critical. I mean, if somebody can have a completely healed mucosa, even endoscopically look pretty well, but they have stenosis or they have other issues going on, you know, extraluminally or luminally that can really impact their lives. So, you know, I think that I'd like the committee to comment on this.
And is it healing with a capital H or a small H?
Endoscopic healing, and the definition of endoscopic healing, there was a recent review about that, it's all over the place, even with the scoring system. Yes, 0, 24.
Okay.
So precisely what they said. So the next step, let's look at the data behind mucosal healing. All of the data is based on retrospective post-hoc analysis, as Dr. Colombo mentioned. In the step-up, top-down study, which initially had 133 patients and proved that early combined immunosuppression was superior than conventional management to achieving mucosal rates, there was an endoscopic sub-study that enrolled 49 patients who underwent colonoscopy at year 2 and then were followed at year 3 and 4 with clinical questionnaires that asked about their disease status, their flares, hospitalizations, and surgeries. And what was found was that the patients who had achieved endoscopic healing, here defined as a simple endoscopic score of 0 at year 2, had sustained clinical and steroid-free remission at years 3 and 4. What was not statistically significant but was greater in number was that patients who had mucosal healing at year 2 had less flares and less fistula development. So again, this is based on post-hoc analysis of the step-up top-down study. More data comes from the Extend trial. Again, post-hoc analysis. This time it was underpowered, and so we don't have great data. But in the Extend trial, as you recall, it compared adalimumab to placebo and calculated mucosal healing rates. And what was defined as deep remission was a CDAI score of less than 150 and lack of ulcerations on endoscopy. And they looked at the rates of deep remission in the adalimumab group compared to the placebo group, and then they evaluated the impact of early deep remission on long-term outcomes. The main point that I'd like to stress from the Extend trial was that all-cause hospitalization among the adalimumab group who had achieved deep remission was 0. So none of these patients who had deep remission at week 12 had surgery or required hospitalization. The group that did not develop deep remission at week 12 had some hospitalizations.
But it's important to point out that only 1 in 6 patients achieved the deep remission.
Yes.
But it raises the question of how many patients we can get to the ultimate target
Exactly.
therapies that we have and the way that we can use them now.
Since you've done an MNT on this concept, I think you did an MNT for ACT, for the collective themselves, but do we know how many patients we need to treat to get one more patient into endoscopic?
No, and also we don't know the number needed to harm, and we could maybe the best way to evaluate this is the ratio of the NNT to the NNH, because you could push things too far and actually harm more patients than help.
To go to his second question, which was how likely am I to achieve mucosal healing? You're telling me it's important, but how likely am I to actually get it? In a retrospective cohort of 67 Crohn's disease patients who had endoscopy and ulcers at baseline and then 2 consecutive endoscopic procedures, it was found that at 52 weeks, about 45% of patients would have mucosal healing. What's interesting, though, is that the factors that were associated with achieving mucosal healing was adjustment in medical therapy according to endoscopic findings. So this lends credit to the treat to target idea that you're more likely, or there's a higher probability of achieving mucosal healing if we're adjusting your therapies according to what was found on endoscopy. So we don't have a lot of good data. Enter React-2, which I rudely cut off Dr. Colombel from continuing about. But what I'd like to talk about React-2 is that this is an ongoing trial, which is going to be very exciting because what it'll do is it'll give us the prospective data that we need to prove a treat-to-target approach based on endoscopy. It's recruiting about 1,200 patients, and they'll be randomized to a conventional step care algorithm where treatment intensification is based on symptoms, and an enhanced treatment algorithm where treatment intensification is based on endoscopy. And the primary endpoint would be risk of Crohn's disease complications, surgeries, hospitalizations, fistula development at 1 year.
I would say my is that 5 years is not long enough. I mean, if you look at when the complications occur, if someone is not presenting with a complication, 1 year is a very difficult endpoint to really show difference potentially. The baby before this, which is React-1, which used Harvey Bradshaw only, and having people coming every 3 months. So that was more, instead of your target was symptoms at that one, and it was intense tight control of symptoms every 3 months versus the standard of care. And of course, when you look at symptoms alone, there was no difference every year between come in when you're sick versus all intensifying based on your Harvey Bradshaw. But they did show up to 2 years that there was starting to separate the curves of infection, complication. So I think I'm a little concerned about
The 1 year follow-up.
and whether that was seen. You're going to show comment, I'm guessing. But any kind of longer term follow-up is really what's going to help us truly answer the question that this guy wanted to know, is whether mucosal healing will change my trajectory. It's not about in 1 year from now. It's I've got a lifetime of this disease. So are you changing my sort of history? And I think it's very important.
Exactly. So just to recap the evidence that we discussed in this short period of time, mucosal healing is associated with better clinical outcomes, but this is all a retrospective post-hoc analysis. It's a feasible target if you apply a tight control algorithm, and React-2 is what we're waiting for. It'll compare the intervention approach based on clinical symptoms with approach based on mucosal healing.
You showed on the right side there that you can achieve mucosal healing by adjustments to therapy. Is there any retrospective data for long-term follow-up patients? I.e., like if you go to the slide before this, these are patients with single agent therapy, and you looked at the deep remission patients. Do those have more indolent disease? And that's why they've done better. And now, can we take the patients that might be more refractory to single therapy, we give them a target? Do we have any retrospective data to say that they too are like this deep remission group?
No, because we don't have long-term follow-up studies. And this is the main problem in IBD as compared with rheumatoid arthritis. The longest studies that we have are looking at 2 years. This is the main problem.
So the next target that we're going to be talking about is biomarkers. So very exciting. So our case presentation is a 35-year-old male, the same patient from the first case, who's now coming in for his 3-month follow-up. So now he feels well. He's had complete resolution of his pain and normalization of his bowel habits. You send some labs. He has an elevated CRP at 10 and an elevated fecal calpro at 500. He asks, again, this is a very medically savvy patient, one of Dr. Rubin's medical malpractice lawyers. He asks, do I need a colonoscopy? And do I need more adalimumab? So Dr. Colombo, do you think he needs a colonoscopy? Do you think he needs more adalimumab?
So,
3 months.
But remember, this is the 3-month follow-up.
3 months.
yes, this is 3 months follow-up, so it's maybe a little bit early, but still, I believe that this guy is not perfectly controlled. Maybe I will repeat the CRP and fecal calpro because we know that this can change, especially the fecal calpro. If the calpro is still elevated, I think it would be appropriate to do a colonoscopy, and then if it's showing active disease, step up.
Would you step up without doing a colonoscopy?
I must say, most likely not in clinical practice, even though this is what we did in the clinical trial. This is where
Marla, what would you do?
So before I answer, John said that the calpro and CRP in calm changed at 3 months. Meaning, did you find a predictor of a year early? Okay, that was what I wanted to bring up. That early you could see a change, and there's studies that show if you don't see you know, you need to escalate.
So what do you tell them?
So in this patient, I would just check a drug level, make sure they're optimized before I would necessarily endoscope them at 3 months. Check a drug level, optimize, repeat CRP calpro in 1 month, plan for a scope at that time. And I would scope even if the labs are normal.
At 3 months.
3 months?
No, I'm saying.
Oh.
No. I'm saying that.
Relax, Dr. Rubin.
Don't worry, it's all good. Repeat it at 1 month and then plan for my 6-month treatment target scope. So that's kind of what I would do with this.
All right, Bruce is
Like
agreed.
she said. No, because
Peter?
you have corroboration
Peter, is that,
of two different
uh,
independent.
is this gonna work?
Yeah.
What was the initial CRP in Calpro? Was he starting off at 60 in 2000, and now he's much better? We just need to give a little more time. I mean, that's a key piece of data because if he started off at 15 and 600, there's not really much of a difference. And I would check the level of antibodies because he may not be better because he may be expecting antibody format, which wasn't done with it. But that's the perfect time to do it. But if he started at a CRP of 60 in the Calpro in 2000, I would probably continue to give it some time to work as he's feeling much better.
Comment from the committee on this. I find adalimumab 40 milligrams every 2 weeks. Let's say this is a 35-year-old, 240-pound, former football player, lineman, big guy. 40 every 2 weeks is almost routinely inadequate.
It's inadequate in about half the patients.
Yeah, it's pretty. I mean, comments about just even building into the follow-up optimization, level or whatever you like that in patients like this. What your practices.
Yeah, I mean, all of us, we get it now at this point, make sure it's unoptimized, make sure your healing is probably underdosed, which, as you noted, for adalimumab, we know you see that's true, and I think we also believe in based on the escalation data. And so I think you're right, you have to early figure out whether your patient is optimized or not, wait for them to put themselves failure. I mean, that's the whole, to me, this whole concept that you're introducing is all about being proactive about management. I mean, the concept of reactive to a patient's symptom or having them come in, you have to train your patients to think ahead. And this is where biomarkers to me are very helpful, and drug levels. Like, get them obsessed with a target that is an objective marker, not just my symptom. I think that's important.
And remember that CRP is a good biomarker for TNF response because it's downstream of TNF. So if someone starts with an elevation and you don't normalize it within 3 months, the patient is not fully responsive.
Jean-Fred, how good is CRP? Don't a lot of patients never make a CRP?
I mean, based on data, maybe 20% of patients will never make a CRP report.
So I guess
just a point to Marla, I completely agree with you, and we are strong advocates for proactive monitoring. Even though in the HGA guidelines, they are advocating against proactive monitoring.
So I guess our takeaway from our expert panel at this juncture is that they would check drug levels. They wouldn't necessarily escalate treatment right away, right now. But Dr. Colombo, what about the CALM trial? What about the pièce de résistance of everything? This was the baby. This was the randomized. So at the time when the STRIDE guidelines were created, we didn't have good data about biomarkers as targets for Crohn's disease or ulcerative colitis. Then the CALM trial occurred, and this was a randomized controlled study, and it took adult patients who were immunomodulator and biologic naive, had moderate severe Crohn's. They had to have active endoscopic disease and a baseline CRP that was greater than 5 and a calprotectin that was greater than 250. And it randomized to these patients to either a clinical management group where treatment was escalated according to symptoms, or a tight control group where treatment was escalated according to symptoms and biomarkers, fecal calpro and CRP. And what they did was initially all patients received a prednisone first, and then 9 weeks before randomization, and then they were randomized to either the clinical management group or the tight control group. Patients were assessed at weeks 11, 23, and 35 to see if they met pre-specified failure criteria. So in the clinical management group, this constituted a suboptimal decrease in CDAI, or a persistent CDI greater than 200. In the tight control group, and the reason why I'm showing this slide is because to show how much the tight control group focused on biomarkers. So essentially, if you've had one of these, a CRP greater than 5 or a CalPro greater than 250, that met failure criteria and your therapy was escalated. The primary endpoint was mucosal healing at 48 weeks, and mucosal healing here was defined as CDIS less than 4 with no deep ulcerations. And what we can see is that there was a statistically significant greater rate of mucosal healing, more patients with mucosal healing in the tight control group as compared to the clinical management group, which we could figure. And then other secondary endpoints at 48 weeks that were examined included deep remission, which was defined as both a CDAI less than 150 and mucosal healing, no deep ulcerations, biological remission, which was normalization of the fecal calpro and the CRP, complete endoscopic remission, which was a CDIS of 0, and an endoscopic response, which essentially was a CDIS decrease of about 5 points. And we saw that there were higher rates of deep remission, biological remission, and CDIS that were statistically significant, and there were superior but not significant rates of complete endoscopic remission and endoscopic response in the tight control group. So what is our takeaway? Our takeaway, should it be keep calm and treat to target? Someone had to make the pun. Because calm is really the first study that showed that a tight control algorithm that was based on objective markers really improved clinical outcomes. But now we're in a different era. We're in the post-calm era, and there's a lot more dissidence, I guess you could say, about what our new guidelines should be. This was a letter to the editor by Dr. Laurent Perrin-Bureau, who essentially recommended that the STRIDE guidelines, who he was the first author of, should be changed and should now incorporate fecal calprotectin and CRP. So, Dr. Columbell, do you think that we should shift and include CRP and fecal calpro as part of our formal targets?
So I think you are mentioning there are two concepts. There is treat to target and tight control, which are linked. Treat to target means that you need to treat the target, which so far is endoscopic healing. And in order to reach the target, you need to apply this tight control strategy. It means that you need to control your patients based on symptoms, biomarkers, drug levels, and then you are more likely to achieve your target using tight control than using just loose control based on symptoms. This is a take-home message from CAP. Basically, you need to follow your patients on objective data on the top of clinical symptoms. And look, we achieved very good mucosal healing data. These are the best endoscopic healing data so far. It's 40%. The recent ustekinumab data is 15%.
It's important to know how long those patients have received them, right? These were really soon after diagnosis in that study. These were naive patients. So this is different from the patients who take these 6, 7, 8 years and followed them for a while. It's apples to oranges when you're talking about those patients.
You need to adapt the strategy for patients.
So our next target that we'll discuss is drug levels. We have a new patient now, a 45-year-old female with Crohn's colitis who's on infliximab 5 every 8 weeks, who's coming in for 6-month follow-up. She feels well. She's had complete resolution of her pain. She's had normalization of her bowel habits. Her labs are pretty normal. She has a CRP of 5, upper limit of normal, fecal calpro of 200, same. So she asks, do I need a colonoscopy? And do I need those pricey drug levels?
Because of the money.
I'm like distracted. Yeah, not listening. No problem. First of all, I think the colonoscopy is we all agree. Actually, I'm not sure because Ryan can tell me. Does everyone do a treat to target colonoscopy at the IBD patient? Meaning within 6 to 9 months after starting therapy, our patients routinely getting a colonoscopy. So that's better than most places. Yeah.
So you're saying yes to
Yes,
that
to the
question.
first one.
And what about the second question?
So let's talk about that.
Pricey drug level.
This patient is in maintenance, essentially. So you passed your window of opportunity for induction optimization. We want to make that point that induction optimization is probably where your money truly much further.
You mean she should have been tested earlier already?
Yeah.
Automatically, everybody, everybody.
Everybody.
Ooh,
I'm just telling you, you told me it's okay for CRP and Calpro. Why can't you do a drug level to see if you've optimized? Why are you waiting for a patient to fail?
But no data.
I mean, but she's feeling well and her numbers are good and that's why she's asking
But
about all this.
in 3 months from now, she could be having antibodies and she's not going to no longer respond to it. So it's the same concept that I'm talking about. I'm not saying it's dogma, but we're talking about this idea. If you could proactively be aware that this patient is going to develop antibodies if their drug levels are persistently low.
Peter, you gonna do it?
The drug levels aren't always pricey. If you order through LabCorp, you don't have to go through the authorization and fighting with Prometheus that you have to, which makes it much easier. For that segment of patients who can't go through LabCorp, then it's a different battle. And that early one I get, and then the patient starts to get the bills and it gets more difficult to get the subsequent ones with that. And that's just the thing. And I'm assuming that this is 6 months after starting in place,
Yes.
not that the patient's been on it.
Yes.
Yeah, so absolutely. Patients should have colonoscopy.
So the takeaway is we should do drug levels.
It's not, I would say if you ask 10 people, maybe not.
Yeah.
Well,
Dr. Sands,
let's
would you
take another scenario. If the patient has a colonoscopy and there's perfect mucosal healing at that point, how many of us would get a drug level in that scenario?
Why?
It's
Why?
not-
No, but
Asking
everything,
the whole
you've met, you target has been met.
She's gonna lose her target.
She's gonna lose her, the
So,
sky is
so
gonna
I guess
fall.
let's open it to the, so from the audience, how many people would get a target, would get a drug level if on colonoscopy she had mucosal healing?
Proactive TV, that's her philosophy.
And also she's on mono,
And she's on one.
Yes.
the higher risk of developing antibodies. So you need to anticipate. It's always the same concept.
But the target has been achieved.
Yes,
But she may lose the
So there are other
Oh, you're
perils.
such a pessimist.
Well,
Yeah.
No, there are other perils. I mean, let's say you get a level, let's think this through. If you do a level and it's 0, there's no circulating Remicade. That person's at higher risk for developing antibodies.
I mean, she just got better spontaneously.
Let's say you do it and it's super therapeutic, massively super therapeutic. Could you offer this patient perhaps a reduction in her Remicade? I mean, there are things you could act on that level at that point and make it, again, it being proactive and being more bespoke and tailor making.
But I agree it's a problem of the cost in this.
Yes, it's a problem of a
Okay,
cost.
go ahead.
So drug levels were not part of the STRIDE guidelines, but we know that drug levels, as has been reiterated by our panel, are important for a tight control and a treat-to-target approach. This is a retrospective observational study where they looked at the outcomes of proactive therapeutic drug monitoring. And again, proactive therapeutic drug monitoring is defined as a assessment of drug levels and antibodies at a predefined time point where the patient is asymptomatic and then adjusting the dose to a specific target. This study had 126 patients who had all achieved remission on Remicade. And what they did was they found that patients who had had proactive therapeutic drug monitoring with a goal of about 5 to 10 had a greater probability of remaining on infliximab. That probability was greatest if the trough concentration was greater than 5. This is unvalidated in the prospective TAXIT trial, which was a randomized controlled trial with 263 IBD patients, again, who had achieved clinical remission on Remicade. This time, patients were randomized to either receive dosing based on their symptoms or on trough with a goal of 3 to 7 here. Again, we see that targeting that trough, patients who were in the group where dosing was based just on a range of 3 to 7 had more efficient use of the drug. Continued trough-based dosing wasn't superior to clinically based dosing in terms of remission outcomes at 1 year, but there were fewer flares in this group.
And that was after you already reached the target.
Yes.
So the point of TAXIT is actually the optimization, the optimization, not the randomized arm. I think it taught us a lesson that even when patients say they're feeling well, and when you actually, their symptom description versus objectifying it a little bit, and paragraphs, it's not that objective, but actually measuring, and CRP, that they do better. CRP's drop because you've actually optimized the drug level irrespective of symptoms. It's the same as calm using Calpro and CRP, so why wouldn't you think of it in that exact same way?
I also think that on that, in clinical practice, that separation gets much greater as you follow it out years down the road, much greater.
And there is a follow-up of TAXIT showing that.
But what about this fight that we just had about reactive versus proactive therapeutic drug monitoring? This was from Adam Sheffitz. It was a retrospective study, 264 IBD patients. And this was a group of patients that was receiving either proactive or reactive therapeutic drug monitoring. And reactive drug monitoring here was defined as an assessment of a drug level and antibody when symptoms were occurring or there was a loss or an infusion reaction occurred. And here we find that proactive monitoring with a trough goal of 5 to 10 had less probability of treatment failure. So in the proactive group at 1 year, about 6% of patients had a risk of treatment failure compared to the reactive group, which had about a 60% risk of treatment failure. And there was less surgery and less hospitalization in the proactive group. So what's our recap? Proactive drug monitoring is the way to go. It's associated with longer duration of biologic treatment, less treatment failure, surgery, hospitalization. It's integral to a tight control approach, but it's not part of the STRIDE guidelines. And we don't have an optimal trough concentration established yet. So our next case, we're going to be talking about the target of clinical versus endoscopic findings. So this is the same patient, 45-year-old woman on infliximab. She came for a 6-month follow-up. She was feeling great. You check the drug levels. Her trough is 7. She has no antibodies. Her CRP and her fecal calpro are okay. You do her colonoscopy. She has few scattered aphthous ulcers in the terminal ileum. These are the ulcers here, 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 here. So panel, what would you do with her Remicade?
You should have shown fewer.
Yeah. Okay, well let's pretend this one isn't here and this one isn't here.
The first point is that across all clinical trials and drugs, this is true for all anti-TNF, this is true for Velo and ustekinumab. The ileum is the most difficult place to heal. This is consistent across all drugs, so we should know that. So the problem is that we don't know what could be the long-term consequences. Let's say there are 2 or 3 aphthous ulcers, less than that. Here I think it's.
Yeah, let's say it's 2 or 3.
And the answer, I don't know.
Oh, that's refreshing.
I mean, there are 3, no?
Realistically, 2 or 3 aphthous ulcers,
Yes.
not what we just saw. You probably will not dose escalate.
And do
Because
we
there's
know?
expense,
Do we know
probably
whether
not
this
a lot.
strategy works? Do they get better?
Yes,
Mostly.
yes,
When you ramp it up,
yes.
because that's where this is heading.
No, there are data showing that there are data showing association between higher drug levels and endoscopic healing as compared to drug levels and clinical remission.
So this 5 isn't good enough.
But all cross-sectional
This is why
data,
I say association.
not, we see the ulcers, we ramp up the levels, and we see healing.
This is why
It's all
Yeah,
cross-sectional.
the association.
But the thing that I often say, when
It's not
I
a
see
great
patients propose is, these drug level ranges are population means. That doesn't mean that for an individual patient, you can't do better. An individual may need more drug to get the disease under control. So even if you see a therapeutic range and someone has active inflammation, it doesn't mean that they're not going to do better by having more drug super therapy.
I'd say the level of 7 is too low for mucosal healing. The association rate is shown in the level around 10 plus for mucosal healing. I'm not saying that she had a level of 20 should look any different. We have no, that's not the data we have, but we have cross-sectional data suggesting a higher level. And that's what I think we would all probably do, is that we would opt, unless your level was 34 or your level was like sky high, we would probably ramp up the level.
This isn't easy. I mean, you don't need a single acronym trial to look at this and not know that this patient in a few years is going to be presenting with obstructive symptoms or fissure or something like that. This is pretty active disease.
If the patient had 1 to 2 to 3 aphthous ulcers, would you would just continue?
Close enough.
And who's to say when you switch them to something? That's what always makes me upset, is that the patient was switched to another therapy for like 4 out of 5 or 5. We know that if you look at the Stelara data, for sure not, you're gonna get that much better. So part of it is, are you really gonna do better with something else? And that's what needs to come into play.
Yeah.
Is this a true mechanism failure? Sure, go to something else. But if it's optimization or just wait.
So I gather that she's getting to get more drug.
Well, no, they're saying that at this stage, she would get drug here,
No,
but
right
if she
here,
had,
right here and now.
yes, this lady, but if she had 2 to 3 ulcers, you would not.
Mhm.
But then are you really ascribing to the mucosal healing that you guys have recommended in this trial?
It depends on where we draw the line, and that is not well defined yet.
Is anyone going to be adding a thiopurine here or just upping the dose?
Here?
I mean,
Here, they're gonna up
No,
the
I'd rather
dose.
up the dose.
Oh,
Okay.
the hell with Sun. Okay, go ahead.
So our last target,
Yes.
so,
No, it's a different thing.
Oh, okay.
And actually, to your point, Peter,
Yeah.
it's likely, but retrospective data that the impact of azathioprim in Sonic was at least in part linked to increasing the levels, and not a synergistic mechanism between two drugs.
Okay.
so the last target that we're gonna discuss is histological healing. This is a 35-year-old male with ulcerative colitis who's on infliximab 5q8, who's coming in for a 6-month follow-up. He feels well. He's had clinical remission, essentially according by the STRIDE guidelines, resolution of his rectal bleeding and normalization of his habits. And you discuss the plan for colonoscopy because it is his 6 months. So he asks, what are we looking for? He's also savvy and he wants to know, are you looking for mucosal healing here? Are you looking for something deeper, Dr. Legnani?
I'm looking for mucosal healing. Or a significant endoscopic response to
Okay.
therapy.
Gonna compare it to the last one.
Correct, well, that's.
Okay.
So, according to the STRIDE guidelines, the target essentially is a composite, like we discussed, clinical and endoscopic remission. There was no mention of histologic healing in the original guidelines. Why is that important? Because histological healing has been shown to have improved outcomes in patients with ulcerative colitis. So we're aiming for this deep remission for patients where we're looking for clinical and mucosal healing, but should we instead really be going for complete remission, where we're going also for histologic healing? Do we have data? We kind of do. This is a prospective study of 91 patients who had ulcerative colitis who were followed over 72 months. And the goal for this trial or for this study was to analyze the value of histologic remission versus endoscopic remission for predicting outcomes of steroid use, hospitalization, and colectomy. So essentially, all of these patients had a scope at baseline. Random biopsies were taken. The biopsies were assessed by one pathologist according to Truelove and Richard's index. And the endoscopy itself was scored according to the Maia score, the Marion index. They dichotomized the findings as either patient was in remission or not. And the first thing that they noted was that there was a concordance of about 55% among endoscopy and histology and clinical, so moderate agreement. And what they additionally found was that 75% of patients who were in endoscopic healing were not necessarily, or were not in histologic healing. The takeaway from that is that endoscopy, 75% who had who endoscopically looked healed did not have histologic healing.
Doesn't say that there.
Oh, no,
It's right there.
also in the
They were also, so 25%.
Yeah. Oh, sorry, yeah.
No,
Yes,
say it
yes.
again.
75% of patients who had endoscopic healing were also on histologic healing. So 25% of patients did not have histologic healing despite having endoscopic
I don't
healing.
think they had no one reading the slides because I think it's higher than that. But, I mean, it looks good, but the pathology comes back with,
More than 25%.
I think it's way more than 20.
Again, it depends on the definition of histological healing. And there is
Right.
one definition now which is based on the North index that Laurent has developed. It should be a North index of less equal to 1. There is no consensus. The most important. And
Jim, what do you think? Don't you get it?
Mabel, what do you comment as what would be for you histological healing?
And put it into English, this means no ulcerations and no neutrophils.
So absence is disease in both the Nancy index and the
Neutrophils,
So
right?
if the active inflammation of neutrophils will mention that, and it's basically the same difference. If it's greater than 50%, it's moderate. If it's less than 50% of the crisp, it's not. So leaving it's divided up by number.
So in the same study, that we just looked at, the prospective study of 91 patients who again had endoscopy at baseline and then had follow-up 6 years later just by clinical record review, has found that the histological remission predicted reduced steroid requirements and reduced rates of hospitalization. But there's limitations, as you just heard. There's a lot of different histological scoring systems that have surfaced from the 1950s. None of them have been validated, and we don't have a standard definition for remission.
Actually, there are two indices which have been validated, the NORS index and the Hobart index. What has not been validated is the definition of remission and response.
Mm-hmm.
That's a very
Yeah.
So a recap for this section is that maybe we should be going for histologic remission for that complete remission. It's predictive of reduced steroid requirements and reduced rates of hospitalization. But like we just heard from Dr. Colombo and Dr. Sands, there's no standard definition for histologic remission. And at the time when the STRAT guidelines were developed, it was just an adjunctive target. Do you recommend at this time that it remains an adjunctive target? Or should it come up to a primary target?
Ideally, and this is what we designed with Ryan, we should do a prospective study comparing treating to clinical remission, endoscopic remission, and histologic remission. It's a very difficult study to do. It's a $20 million study, but we would like to do. The problem, imagine that you have a patient on 5-ASA doing perfectly well. Endoscopy score 0-1. And Mabel say no, there is still a histological activity. Would you step up for NTBO, for instance, in this patient? It's a tough sell. But this is what we should be doing. If we want to...
We don't know.
If we want to...
How tight do you get?
I mean, there's actually a paper by David and Christensen who actually looked at in the scopes they were doing for colon cancer screening, they looked at the histology and then looked at these patients, like it's retro, but looked at them forward. And he showed that flare-free survival was much better if you had no active inflammation at the time.
But at the moment, that's not the guidelines.
Not the guidelines, but that's what we need to show is that histo is different than endo.
Right.
It's different than clinical.
Micro and
That's what
macro.
we're saying.
Right. Okay.
So our conclusions, what have we taken away? These are my personal conclusions. Feel free to object to them. But treat to target and tight control are complementary. They should be tailored to the individual patient. The guidelines for endoscopic mucosal healing were based on post hoc analysis, but React 2 is going to give us the prospective data that we need. Biomarkers should be incorporated into the composite target if you're applying that tight control algorithm. Drug levels should be adjunctive targets. And histology should be incorporated once we have a standardized definition and scoring system. Panel, do you agree?
Agreed.
Yes.
Okay, thank you.
Brilliant.